Thanks, Bill, for that really great introduction. And I shall advise all the speakers that everyone gets a standing ovation here because we believe in active applause. So I'm going to first remind you that the bibliography of the workshop is on the workshop webpage, so many of the things that are cited here will be there for you to access afterwards. And I am delighted to see this workshop come to fruition. We've been talking about equity for a long time, and as Bill implied, this may indeed be a transformative moment in the roundtable and perhaps in health equity issues and obesity in the United States. So I'm just going to take a few minutes and set the stage for this. This is the question we hope to answer in this workshop. Why is obesity a health equity issue, and what can we do about it? I'm going to start with some definitions, because if we're going to look at what health equity issues, we'll need to have a common definition. I have a few slides with text that I've taken directly from the Robert Wood Johnson Foundation booklet on what is health equity and what a difference a definition makes, partly because I think these are excellent definitions to put us all on the same page, but also because the report itself is a reference point for those who are less familiar with these issues of why this definition is something that is guiding us. We are not going to debate the definition, but hopefully you'll see by the end of the day what this actually means. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs and fair pay, quality education and housing, safe environments, and health care. Disparities are the term that's more familiar to a lot of people. We've moved toward health equity, which is the aspirational goal, and disparities are the measure of a lack of health equity. So for measuring, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. Now, this next statement is a key because we don't want to only close gaps without looking at the trajectory of health in general. So this second part of this definition says, progress towards health equity is assessed by measuring how the disparities change over time in both absolute and relative terms. The gaps are closed by making special efforts to improve the health of the excluded or marginalized groups, not by worsening the health of those who are better off. Because, as you may know, some of the disparities may be closing because the health of the reference population, low-income whites, for example, may be getting worse, and so you see less difference, but that's not what we're looking for. We're looking for lifting all boats and then closing the gaps at the same time. Who are the excluded and marginalized groups? I think this definition is becoming more and more inclusive. Today we're going to focus on racial ethnic minority groups in particular, in some cases low-income populations, but excluded or marginalized groups, according to the RWJF report, are those who have often suffered discrimination or been excluded or marginalized from society and the health-promoting resources that it has to offer. They've been pushed to society's margins with inadequate access to key opportunities. They are economically and or socially disadvantaged. And one of the problems here when we talk, I've been using the term priority populations, which has been developed to refer in general to populations that deserve priority in our public health efforts and prevention and treatment efforts, because the terms like socially disadvantaged are themselves disempowering. So even though we're not going to go into, a political correctness issue, I urge you to think about these groups as groups with assets and the power to overcome some of the disadvantages and not just look from a deficit model. So the workshop objectives are to consider the history of health equity issues and demographic groups that have above average obesity risk, principles and approaches to addressing these issues in obesity prevention and treatment, equity issues related to the creation, implementation, and evaluation of equity-oriented programs, policies, and system changes, including those that affect healthy eating and active living. And finally, to identify research needed to inform and mobilize equity-centered obesity prevention and treatment actions in the field. The flow of the workshop is to first outline the problem to make sure everyone recognizes the disparities that exist in the populations we're going to focus on, and then talk about how we got there, some of these social determinants and contextual issues. The rest of the workshop will be devoted to solutions. So in session 3, just after lunch, the lessons from the field, achieving equity and obesity through community and public health approaches. We'll have some examples of projects that have done that, and we'll be able to discuss the approaches they used. And then the 4th session, further lessons looking at obesity treatment in healthcare settings. And then we'll have a wrap-up with commentary from some of our colleagues about their takeaways. So the last few slides are to help see the conceptual framework that we're dealing with. There's an underlying assumption here that we have to go upstream, and that the gray shaded area, we focus a lot on weight-related behaviors and outcomes, which leads us to a focus on individual behaviors without looking behind the curtain. Like what perpetuates those behaviors, what makes it difficult to adopt other behaviors. So we're going to go to the intermediate variables that determine, in a sense, the weight-related behaviors and outcomes, and then we're going to go and look at what determines those intermediates. So I did a thought exercise, some help from the planning committee. So these are the outcomes we often focus on or need to focus on in terms of the proximal, what individuals are doing and how their weight is managed, whether they have obesity, whether children grow and develop along the correct trajectory as we think it should be. Here are some variables that you may hear mentioned, food-related, physical activity-related, and then chronic stress, including financial, which is definitely a correlate of obesity, sleep health, and resource limitations that may affect behaviors. So you can just look that over, and I'm also doing this to have them on record so that they'll be in the archive with the workshops. You can refer back to them. So these are all the different things that may affect whether people buy healthy food, control their calories, and so forth. It's going to become overwhelming in a minute. The next is a list of the categories that you could use to see upstream determinants: historical, social, economic, physical, and policy context. And I think my impression here is that there are a lot of things we take for granted. So if we have or don't have these things, if we have all the legal risks and protections, if we don't have exposure or problems because of institutionalized racism or discrimination, if we have employment, good education, occupations, and neighborhoods that provide what we need, and we have the political voice to change things when they're not right, it looks easy, or at least it looks possible. But if we don't have them, and this is where it becomes overwhelming, there are a lot of different things that can go wrong. Income is not just income, a category of the poverty line. I mean, it's how much debt do you have? Do you have wealth? Do you have, inheritance? Are you making minimum wage? Is the market working for you or against you? So this last slide is not intended for you to read everything here. It is to put it on the record, but to say that we can't oversimplify what it means to address disparities and look at health equity issues. There are a lot of things going on, And sometimes the average person who is in a socially disadvantaged situation is dealing with a cumulative set of factors that we need to help people in those situations overcome. We can't overcome the situations for them, but we can make it more likely that they will overcome these factors. As I made this slide, I found myself adding, because of the current climate that we're in, political voice with a subhead of voter registration. We can't even take that for granted anymore. And this is not only low-income populations, it's populations who are identified for some sort of discrimination. So I'll stop there, and we will move on to the first session, which is to look at the disparities themselves. And our first session is going to be 3 speakers who talk about the different disparities affecting different ethnic groups. The first speaker is Dr. Cynthia Ogden. She is she's from the Centers for Disease Control and Prevention and is the N. Haynes Analysis Branch Chief at the National Center for Health Statistics and an adjunct professor at the George Washington University. So each of these presenters will present something about disparities in different groups. We'll go on to the second and third speakers, after which we will have time for Q&A from the audience. So let me welcome to the stage Dr. Ogden.